Hello, and happy summer! It's been an incredibly hot one so far here in the Southwest, and I hope you're all finding ways to beat the heat and stay cool. It's great to be back with you again, and this month we're going to talk a little nerdy and dig into 5 important papers that have come out within the last few months. You may already be aware of some of these, but let's get busy and talk about how these might change our practice in the upcoming months. Are you ready to be a nerd with me?
Talk nerdy to me.
This month, we're going to talk about some critical care topics that I think we can all use. We see cardiac arrest patients and hypotensive patients all the time, so this is stuff that you'll be able to take with you on your next shift. First, we're going to dig into 3 cardiac arrest papers and talk about an update on the antiarrhythmic discussion. Then we'll talk about epinephrine use, and we'll wrap up the cardiac arrest discussion by talking about the airway management of these patients. Then we'll move on to talk about vasopressor administration in the hypotensive patient, and finish up with a good dose of neurocritical care. Sadly, I still don't have any financial conflicts of interest to disclose. I ought to work on that. Since we're doing disclosures, I will admit that I'm a crazy cat lady. After all, the first step is admitting that you have a problem. Although, since I do only have 1 cat currently, I think the problem's under control. Since we're going with the cat theme this month, I thought that for our mental breaks this time, we could enjoy some feline antics with the single greatest cat entertainment device ever created, the box. Now let's get started with our first topic and dig into antiarrhythmics for out-of-hospital cardiac arrest. The question we're interested in is, do antiarrhythmics improve neurologically intact survival after out-of-hospital cardiac arrest? I think that most of you will probably already be familiar with this paper since it came out about a year ago and got some pretty major press. In fact, we talked about this paper on the site a couple months ago. This paper is really important since it was the first really well-designed trial that asked this important question. Here's the update. Since the Kudenchuk trial got published in the New England Journal, a meta-analysis asking the same question was done that included that paper. They included 3 randomized controlled trials and 4 observational trials. But since the Kudenchuk paper is by far the largest trial to date, including 3,026 patients, we can expect that the results of the meta-analysis are going to be impacted by this paper, considering that almost 70% of the patients in this systematic review come from a single trial. But considering that overall it was a really well-done trial, the level of evidence is still going to be pretty good. Let's look at the data. Since they meta-analyzed different studies and ended up with some heterogeneity between the outcomes of interest, I thought it might be easiest to discuss them by event rate since there were different numbers of patients between the various arms. They looked at survival to hospital discharge for amiodarone versus placebo, including data from 3 trials, and for lidocaine versus placebo, including 1 trial. For survival to hospital discharge, there were no significant differences between either of the drugs versus placebo, with 22% survival in the amiodarone group and 19.5% in the placebo group. And for lidocaine versus placebo, there was 20% survival in the lidocaine group versus 19% for placebo. For survival with a good neurologic outcome, they found the same result. 16.5% for amiodarone versus 14.6% for placebo, and 17.5% for lidocaine and 16.6% for placebo, so there were no significant differences between any of the groups. They also looked at amiodarone versus lidocaine, and suffice it to say, there was no difference between either of the antiarrhythmics either. The most important information from this meta-analysis is the data regarding neurologic recovery, with most of it coming from the New England Journal paper. I think we can all agree that if a patient survives, but ends up with severe anoxic injury requiring institutionalization and round-the-clock care, we probably didn't do that patient any favors. They chose a cutoff of a Rankin score of 3 or less, since those patients are at least still moderately functional. If your Rankin score is 3, you're typically still able to walk and can manage some of your ADLs, although you probably need some assistance. However, if your Rankin score is 4 or greater, that's definitely not a good outcome, since a score of 4 means that you're unable to perform your basic tasks of daily living, and 5 is a bedridden patient that needs total care. And of course, a Rankin score of 6 is you're dead. When we look at the patient outcomes in terms of who had a Rankin score of 3 or less, there were no significant differences between either of the drugs or placebo. An important point to consider was that in the paper, they reported 2 different analyses, a per-protocol analysis and an intention-to-treat analysis. Per-protocol analysis means that patients are analyzed according to the groups they completed the study in, whereas an intention-to-treat analysis analyzes all patients based on the groups they were originally randomized to. In this paper, nearly 35% of the patients that were initially enrolled were ultimately excluded from the per-protocol analysis based on their strict enrollment criteria. And so, the per-protocol analysis included only 65% of the patients initially enrolled. If you looked at the intention-to-treat analysis, nearly all of the trends they observed that slightly favored the drugs disappear, which is important to consider since this population is going to look a lot more like the general population that the results are going to be applied to, and therefore the intention-to-treat group is probably a more real-world representation of how this would play out in real practice. Another important point was that when they looked at the subgroups of patients with a witnessed arrest and those whose arrest was witnessed by EMS, survival was significantly better in the treatment arms. This might lead one to believe that getting the drug faster is what matters. However, we have to consider that the paper wasn't designed to look for this outcome at the outset, and so the groups were not randomized for this particular outcome. Also, the number of patients that had witnessed arrests was extremely small, particularly in the EMS witnessed arm. Far too small to base any meaningful conclusions on or exclude that the results were entirely due to chance. This data is not strong enough to suggest that we should be doing this for patients with a witnessed arrest, considering that overall the trial was definitively negative. But it is an interesting hypothesis that ought to be investigated further. The bottom line for this meta-analysis was well stated in the Systematic Review snapshot from May's Annals of Emergency Medicine. Neither amio or lidocaine improved survival to hospital discharge over placebo, nor did it impact what we really care about, neurologically intact survival. All these drugs did was change the destination of death from the field or the ED to the ICU. Considering the costs associated with ICU-level care and the scarcity of ICU resources, this paper suggests that we need to seriously question the use of these agents and consider other therapies for patients with refractory VFib or VTAC. Have you heard about the Crazy Cat Lady Starter Kit? Order yours today, and a box of floofy adorableness will be delivered directly to your door. It's amazing to me that epinephrine has been part of cardiac arrest management for decades, and yet we still don't know whether it actually provides any benefit. And data suggesting that we may actually be causing harm has been accumulating for the last few years as we begin to question its use. To be frank, we generally aren't even sure how it works during a cardiac arrest. The theoretical argument is that it has alpha-adrenergic effects that improve coronary perfusion pressures. However, epinephrine also has a substantial amount of beta-adrenergic effects, which could be detrimental to the patient in cardiac arrest due to increases in myocardial oxygen demand and increased myocardial irritability, as well as adverse effects on cerebral perfusion. In fact, new research is suggesting that use of a beta blocker early on may be beneficial for patients in VFib-VTach arrest. The truth is, we don't know if or how to be using this drug. It's possible we might just be using it wrong. Maybe we should be titrating it in smaller doses, or timing the doses differently. After decades of unquestioning use, it's good to see that we're finally beginning to ask how to more effectively use this medication. Most of us are pretty familiar with this. This is a simplified overview of what the current American Heart Association ACLS algorithm for pulseless ventricular fibrillation or ventricular tachycardia arrest looks like. In the most recent update of the guidelines in 2015, there was much emphasis on the early initiation of high-quality chest compressions and early access to defibrillation. It seems that the earlier you treat the arrhythmia, the better patients do. So it makes sense to ask the question, does early administration of epinephrine improve outcomes as well? This paper came out in the BMJ last year and asked that very question. More specifically, does giving epi prior to the second shock improve survival from VFib or VTach cardiac arrest? This was a prospective, observational cohort study based on data from the Get With the Guidelines Resuscitation Registry, which includes data from more than 300 hospitals in the United States. These authors included only patients that had an in-hospital cardiac arrest. The primary outcome was survival to hospital discharge. They also included two secondary outcomes: the frequency of return of spontaneous circulation, which they defined as a return of a palpable pulse for at least 20 minutes, and survival with a favorable functional outcome at hospital discharge. They enrolled 2,978 patients that were matched on propensity scores, and the groups were well balanced. 1,510, or 51%, of the patients got epinephrine within 2 minutes after the first defibrillation. If we go back and look at that algorithm again, the first dose of epi is recommended after the second shock in the current AHA-ACLS guidelines, so these 1,510 patients got their epi early. The other 1,464 got epi after the second shock, and these authors compared the two groups to see if there was any difference between them. 87% of the patients in both groups received a second shock, and there were no differences between the groups in total defibrillations received or time of resuscitation, which was 20 minutes versus 21 minutes. The group that got epinephrine early received about 3 milligrams of epi on average versus 1 milligram in the group that got it later. As you can see, the patients that got epi early universally did worse. The group that got epi after the second shock was more likely to survive and have a good functional recovery. The odds ratio for survival to discharge was 0.45 for getting epi early and 0.48 for a good functional outcome, and both had significant p-values. It was genuinely surprising to me how often we're giving the first dose of epi within the first 2 minutes of an arrest, long before the second shock. In this study cohort, over 50% of the patients got epinephrine early, and it seems that over time, we're continuing to give it early and giving it early more often. In light of the data in this paper, this is a concerning trend, but it's also really easy to understand why this might be happening. We're so used to being told, earlier is better. We've become accustomed to rushing to meet door-to-needle times, door-to-balloon times. You've all been trained that time is muscle, or time is brain. So naturally, we're all very quick to start interventions. We've seen a big increase in the number of metrics associated with these time pressures, and I suspect that this may play a role in our tendency to jump to these interventions early. The bottom line from this paper is that early administration of epinephrine before the second shock resulted in poorer patient-oriented outcomes. We do have a tendency to want to rush, but this data demonstrates that sometimes we just need to have a little patience. I remember being an intern involved with a cardiac arrest at the beginning of my training. The attending asked me what the first step in running a successful code was, and I'm sure I mumbled something about the ABCs. But my attending looked at me and said, "No, the first step is to stop and take your own pulse. You can't do anything good if you're running around frantic." That was a great lesson, and it applies here too. I also hope to see some more research looking at epinephrine, because despite its long history in cardiac arrest resuscitation, there's so much we genuinely don't know. I wouldn't be surprised if the role of epi in cardiac arrest changes over the next decade, as we learn more about how much, how often, and in which patients we should be reaching for this drug. Ever wondered how to catch a cat? It mostly involves just finding an empty box. Let's move on and talk about our final topic regarding cardiac arrest and discuss airway management. In critical patients, we've all been trained to consider the ABCs and secure the airway. In the setting of cardiac arrest, in recent years, we have amended this to CAB, with more emphasis on getting on the chest rapidly to provide adequate cardiac output and maintain cerebral perfusion pressure. And while we know that maintaining oxygenation is a key part of resuscitation as well, what we don't know is exactly what the optimal strategy for providing ventilation and airway support is in cardiac arrest. Some advocate for passive oxygenation, while others suggest that we should intubate early. Others recommend quick insertion of a supraglottic device. While we do have some data from the pre-hospital setting that suggests that intubation in the field was associated with worse outcomes, we have had little information to guide what we should do in the hospital. So we need to ask the question, how does tracheal intubation during in-hospital cardiac arrest affect patient outcomes? This paper is a retrospective, observational cohort-matched review of data from a multi-center patient database in the United States-based Get With the Guidelines Resuscitation Registry. In patients who had an endotracheal tube in place at the time of cardiac arrest were excluded. Time to intubation was recorded as the time in whole minutes from loss of pulse to intubation. Patients intubated at any given minute from 0 to 15 minutes were matched with patients that were not intubated within the same minute, but who were still receiving ongoing resuscitation. There were 108,078 patients included in the study, and the data was collected from 668 hospitals. 66.3% of the patients included were intubated during their cardiac arrest, and of those that were intubated, 95% were performed within the first 15 minutes, with the median time to intubation being 5 minutes. The primary outcome was survival to hospital discharge. They also included 2 secondary outcomes, return of spontaneous circulation and favorable neurologic outcome. Overall, 22% of the patients included in this analysis survived to hospital discharge, but there was a demonstrable difference in the rate of survival, return of spontaneous circulation, and favorable neurologic outcome, and the patients who were intubated early universally did worse. This unadjusted analysis looked at all of the patients included prior to any attempts at matching, and showed that survival to discharge and favorable neurologic outcome were twice as likely in the patients who were not intubated in the first 15 minutes. The surprising part was how big of a difference there was between the group that was intubated early and the group that was not intubated in the first 15 minutes or not intubated at all. The authors also looked at a propensity-matched cohort in which 86,628 patients were included. They looked at 43,314 intubated patients and matched them on a one-to-one basis with 43,314 patients without intubation during the same minute, although it is possible that some of these patients may have been intubated later, but still within the first 15 minutes. After propensity matching, the differences were less pronounced than in the unadjusted analysis, but still demonstrated better outcomes among the patients who were intubated later. Their sample size was large enough that even though the differences weren't huge, they were statistically significant. However, the difference was most pronounced for the patients that had an initially shockable rhythm, and that's important because those are the patients that are most likely to be salvageable. While I think we would all agree that this is a really important paper, there are a few problems with the data. First of all, it was retrospective, and so we can't really determine cause and effect based on this information. Next, they collected patients from as far back as the year 2000, and there have been a lot of changes in cardiac arrest management between 2000 and 2017. I'm not suggesting that we're necessarily talking apples and oranges, but can we really say that an apple from 2000 is the same as an apple in 2004, or 2009, or 2014? Frankly, I'm not sure you can lump together what happened for cardiac arrest in 2000 with cardiac arrests in 2014, or today for that matter. First of all, the emphasis on good quality, minimally interrupted CPR has changed our focus from drugs and devices to maintaining good cerebral perfusion. What we're really trying to do is resuscitate the brain during cardiac arrest, since ROSC doesn't really matter unless the brain gets enough blood flow to maintain good neurologic function. We got rid of a lot of ACLS drugs in the last decade, like atropine and vasopressin, and therapeutic hypothermia was just starting to happen in the early to mid-2000s, and this has been evolving over this time as well. One thing that they did note in the paper was that the rate of early intubation declined over the study period, which does make sense considering the increased emphasis on good CPR and cerebral perfusion, with 70% of the patients being intubated within the first 15 minutes in 2000 and decreasing to 63% in 2014. We also don't have any data on the quality of CPR, which also may have improved over the study period given the emphasis on this, and we also don't have any information on how patients were intubated or were ventilated during the study. The data in this study suggests that we may be causing harm by intubating early during cardiac arrest. The more interesting part of this question to me is really why that might be, and there's a lot of potential reasons for that. Number one, are we interrupting compressions to intubate? Every pause in compressions over 10 seconds is a big deal because you lose all the perfusion pressure you've generated with your excellent compressions, and it takes a long time to get it back up when you resume your compressions. Maybe we're pausing too long to get the tube in. With the newer video laryngoscope technology, it's gotten a lot easier to be able to intubate while compressions are ongoing, so maybe these devices will have an impact on these outcomes. Since the data in this paper go back as far as 2000, most of the patients included were probably intubated with direct laryngoscopy, as video laryngoscopes weren't widely available for much of the study period. Number two, are we hyperventilating the patient? Hyperventilation has been shown to be detrimental to outcomes in many other conditions, and we all know that in the adrenaline rush of a cardiac arrest, we tend to bag the patients way too fast. Number three, maybe we're over-oxygenating the patients. There's plenty of data to suggest that in other conditions like MI and in brain injury, hyperoxia is just as bad as hypoxia. So maybe by intubating these patients, we're making them hyperoxic. Perhaps it's the fact that we're resuscitating them with 100% oxygen rather than the intubation itself. Number 4, are we doing ABC instead of doing CAB? We're all trained to think airway first, and maybe in doing so, we're delaying other critical actions like getting compressions going or getting the patient defibrillated. And last, only half of the patients included arrested in an ED or ICU setting. 10% in the ED and 36% in the ICU to be specific. Nearly half the study cohort coded on the floor, and it's not recorded who did the intubation, so we have no idea whether the person managing the airway in a lot of these cases was an experienced intubator. It's possible they may have had a fair number of unrecognized esophageal intubations occurring. The bottom line is that this paper does not support early intubation for patients in cardiac arrest. They found that patients who were intubated during in-hospital cardiac arrest had worse outcomes for every minute as compared to patients who were not intubated. That being said, I don't think that this retrospective paper with a number of weaknesses tells us that we're at a point where we shouldn't at least consider some form of airway management for these patients at all. The way I intend to use this data is to emphasize getting good compressions going with minimal interruptions, getting a mask on the patient for passive oxygenation during the early phase of resuscitation, and getting the patient defibrillated early. Once we're a couple minutes into the resuscitation and the other critical interventions are taking place, I would consider intubating the patient with a video laryngoscope so that compressions can continue uninterrupted, or maybe consider something like an LMA or a supraglottic device if video laryngoscopy is not available to minimize any interruptions to the other critical interventions. And here we have further proof that cats are not subject to the laws of physics. Let's move on from our discussion of cardiac arrest and move on to a new nerdy topic, the use of vasopressors via peripheral infusion. Our next question, then, is can vasopressors be given safely through a peripheral IV? And if so, what are the complication rates? What is the best site for administration, and what catheter size should be used? We commonly see patients in the emergency department that are in shock of one form or another, many of whom require administration of a vasoconstricting agent to restore adequate tissue perfusion. Granted, we don't have good data demonstrating that pressors actually improve outcomes, but it is still standard practice, and traditionally, this has been an indication for placement of a central venous catheter. However, central lines are invasive, and they are not without complications. It's estimated that up to 15% of patients that have a central line placed will have some sort of complication with that catheter that leads to some morbidity. These lines also require time and expertise to place, and in a busy ED filled with lots of sick patients, the ED physician may not be able to place it in a timely fashion. Being able to infuse pressors through a peripheral line would speed the delivery of the drug and free up the ED physician to tend to other patients. But we've always been taught that peripheral extravasation of these agents could cause severe necrosis, loss of limb, or some other terrible complication, and so we tend not to do it. Since the recent PROCESS, ARISE, and PROMISE trials demonstrated that use of a central line with invasive monitoring capability does not improve mortality in patients with septic shock, this raises the question of whether or not we really need a central line in the majority of these patients anyway, particularly if vasopressor infusion for a brief period of time is the only indication for doing so. This paper is a systematic review published in 2014, where the authors essentially reviewed the world's literature on local tissue injury as a result of peripheral vasopressor administration. They located 85 papers that met their inclusion criteria, and all but one of these was a case report or a case series. They found a single randomized controlled trial published in the New England Journal in 2008 And of the 2 patients in the RCT that had an extravasation injury, both had their extravasation occur from a central line. So the only real data we have on peripheral extravasation is based on case reports. And that tells us nothing about the actual frequency of these events, since a case report has an N of 1. Plus, almost 70% of the papers included predate 1980. In fact, 60% of the papers are from 1969 or before, so we're using data that's almost 50 years old to guide our current practice. When the authors reviewed the 204 cases of local tissue injury events from peripheral vasoconstrictor administration, they found that the overwhelming majority occurred when the infusion had been ongoing for greater than 24 hours, with a mean duration of infusion of 55.9 hours. And of these, in 85% of cases, the infusion site was distal to the antecubital fossa. I think these authors came to absolutely the right conclusion when they suggested that we need some good data that demonstrates the actual frequency of these events in a modern hospital setting. Now we move ahead to January 2017. This paper is a single-center, retrospective chart review of 202 patients who received vasopressor therapy via a peripheral IV. While it's not a randomized controlled trial, this is still arguably better than 50-year-old case reports. They included adults who got vasopressors via a peripheral IV in an ICU setting, and they excluded patients that got a central line and who got peripheral pressors for less than 1 hour. They collected data on patient demographics, site and gauge of the peripheral line, and if the patient had any risk factors for extravasation, and what vasopressor was being infused. If an extravasation event occurred, then they recorded the time and the site of the extravasation, the gauge of the IV, and if any intervention was required to address the extravasation. They also documented the severity of injury. The primary outcome was the incidence of extravasation events. Out of the 202 patients they included, 8 had an extravasation event, or 4% of the total study population. The median time to extravasation was 21 hours and ranged from 12 to 30 hours. The majority of extravasation events occurred with IVs placed distal to the antecubital fossa and were split evenly between norepinephrine and phenylephrine infusions. Despite this, all of the extravasation events that occurred were managed conservatively with a warm compress and removal of the IV from the site, and none developed tissue necrosis or required any other intervention. I'll grant you that this isn't the greatest data in the world, as it's retrospective and a relatively small number of patients and events, but overall, I think this probably gives us a much more realistic idea of what this actually looks like in everyday practice. The bottom line here is that it appears that the use of vasopressors via a peripheral IV is generally a safe practice with a low overall rate of complications. Based on the data we have, suggesting that most complications arise from longer-term use and with the use of more distal IV sites, I think we can use this safely in the ED for short-term use, or at least long enough to get the patient stabilized. Considering that many patients only require pressors for short periods of time, maybe we should reconsider the practice of automatic placement of a central line for all patients getting these agents, unless we suspect that the patient will need them for longer than 6 to 12 hours. If you are going to infuse pressors peripherally, here are the suggestions I have to use them safely. Number 1, make sure that the IV you're using is a good IV. It should draw and it should flow, and ideally be 20 gauge or larger. This just isn't the place for the 24 gauge in the patient's thumb. Number 2, avoid using IVs in the hand. And number 3, as much as I like ultrasound, I also suggest avoiding ultrasound-guided IVs unless you've inserted something like a midline or a PICC line. The reason for this is that the standard IV catheters we carry in the emergency departments just aren't long enough to avoid accidental dislodgement when placed in those deeper veins. Extravasation events might not be noticed for quite a bit longer than for something more superficial. So unless your department has arranged to have extra super long catheters, I would avoid these lines in this scenario. Number 4, limit the use of peripheral vasopressors to short-term use, which is generally long enough for us to manage the patient in the ED and gives us time to risk stratify the patient to help us figure out how long we think this patient may require pressors. And number 5, have a protocol to check the site on a regular basis and have an institutional protocol for managing tissue extravasation events. Just in case you ever wondered how to herd cats, here's how. Anyone who has worked in an emergency department where you see patients that come in with intracranial hemorrhage has been told by a neurosurgeon that you absolutely must lower the blood pressure. But there is remarkably little data to guide us regarding how much, how fast, what the target should be, or frankly, whether or not it even makes a difference. This brings us to the final question for this talk. Does rapid lowering of blood pressure improve outcomes in patients with acute spontaneous intracranial hemorrhage? The idea here is that you want to achieve the Goldilocks phenomenon. The blood pressure should be not too low, not too high. You want it just right. Low enough to limit the expansion of the hematoma, but high enough that you're still perfusing the injured brain tissue. In the ED, we typically don't have any means of intracranial pressure monitoring, at least not in the critical first few hours after the hemorrhage occurs. So we don't have the luxury of calculating cerebral perfusion pressures to help us guide our management, which is why we often end up picking a totally arbitrary number and setting that as the goal systolic blood pressure. In 2013, the INTERACT-2 trial was published. They reported a non-significant trend towards improved patient outcomes when the blood pressure was lowered to 140 as opposed to 180 in patients who presented within 6 hours after symptom onset. That's polite medical jargon for there was no benefit. But there were so many problems with this paper that additional studies were needed. Enter the ATTACH-2 trial, which is a prospective, open-label, randomized controlled trial designed to evaluate the efficacy of intensive blood pressure management initiated within 4.5 hours of symptom onset in patients diagnosed with non-traumatic, supratentorial, intracerebral hemorrhage with a systolic blood pressure of 180 or greater. Patients were randomized to receive either intensive blood pressure reduction with a goal systolic blood pressure of less than 140, with the plan to maintain the blood pressure between 110 and 139 millimeters of mercury, or standard blood pressure reduction with a goal systolic blood pressure of less than 180, with the goal to keep the blood pressure between 140 and 179 millimeters of mercury. A control group was not included, so they didn't have a no treatment arm. Nicardipine was the agent used in all cases so that the treatment would be standard between all the patients, with labetalol as a second-line agent if adequate blood pressure lowering was not achieved with nicardipine alone. They enrolled 1,000 patients, 961 of whom were included in the final analysis. All the patients were randomized within 4 hours of symptom onset and had a GCS between 5 and 15 when the intracranial hemorrhage volume of less than 60 mLs on their initial head CT. Basically, they tried to enroll patients that they thought might have some hope of being salvageable. I think that was smart of the authors. There's not much point in randomizing patients that clearly have a devastating or non-survivable injury. They also had a number of exclusion criteria. Those who were anticoagulated or who have a known coagulopathy at baseline, those who would benefit from an emergency neurosurgical decompression and went directly to the OR, patients that had a traumatic mechanism or a known underlying neoplasm or aneurysm were excluded. They wanted to examine people with a hypertensive spontaneous intracranial hemorrhage. They excluded those with severe intraventricular extension or a cerebellar location of the hemorrhage. And of course, the obvious stuff: allergy to the drug they're using, pregnant women, patients with pre-existing DNRs, yada yada yada. The primary outcome in this paper was a composite endpoint of either death or severe disability, defined as a modified Rankin score of 4 to 6, which is a patient with severe disability such that they more or less require constant care, as these folks, assuming they survive, typically are unable to manage their activities of daily living and are typically either bedbound or, at best, unable to walk unassisted. Secondary outcomes included assessment of hematoma expansion at 24 hours and an assessment of functional status at 3 months based on the Euro-QOL score, which I'd never heard of until I looked it up. This particular score, or European Quality of Life Tool, developed in 1987, is a visual analog scale where patients rate their level of health and quality of life. Its other component is a 5-question ranking scale, on which patients rank their perception of their health regarding 5 different outcomes, including mobility, self-care, everyday activities, pain, and state of mind, each with a score of 1 to 3, with 1 being best and 3 being the worst. Think golf scoring. Low scores are good. They enrolled 500 patients into each group and found that at 3 months, there was no difference in either death or severe disability between the groups. In fact, the authors planned on enrolling 1,280 patients at the start of the trial, but enrollment was stopped early at a pre-specified review due to futility when it became mathematically clear that they would not be able to demonstrate a difference. There were slightly more patients in the standard treatment group that had greater than a 33% expansion of their hematoma, but that did not seem to translate into any change in long-term outcomes, and in fact, there was slightly less neurologic deterioration in the standard treatment group, although not significantly so. To me, this suggests that in some patients, size doesn't matter. By the time they get to us, the damage is done, and limiting expansion of the hematoma isn't going to improve their ultimate outcome. Right now, we don't really have much information to help us in terms of figuring out which patients will benefit from aggressive management to limit hematoma expansion, or whether limiting hematoma expansion actually translates into better patient-oriented outcomes. The only things they found that were significant included an increase in overall adverse events at 3 months in the intensive treatment group, and they found that the rate of renal adverse events occurring within 7 days of randomization occurred more than twice as frequently in the intensive treatment arm as well. While the data showed no difference between their predefined groups in overall outcomes, it's also informative to look at the breakdown of the Rankin scores within the 2 treatment arms as well. For the sake of an example, let's pretend that there were 400 patients in each treatment arm that had a Rankin score of 4 or greater. Since this paper used a composite outcome of death or disability, these groups would look the same taken as a whole. But if 350 of the patients in the standard care arm had a Rankin score of 4, while 350 patients in the intensive treatment arm had a Rankin score of 6, that would be a big disparity within the groups in overall mortality that wouldn't be appreciated unless you looked at the breakdown of the functional outcomes within the groups. However, in this paper, there were no differences of any significance between the 2 treatment arms at any Rankin score, so intensive treatment also doesn't appear to convey any functional benefit either. This study is definitely a step in the right direction, but there were still some problems with this paper. The trial was not blinded and was open label, so everybody knew what treatment they were getting. Interestingly, this design should actually favor the treatment arm, but the trial still showed no benefit. If anything, the study demonstrated harm, as the only outcome that was significant was an increase in adverse events at 3 months. There was also a little population bias in that more than half the study population was Asian, and while it's not likely that this is going to affect the outcome, it's still possible that this data may be less applicable to patients of other ethnicities. I'm not super jazzed that they changed their enrollment criteria halfway through the study. Initially, they only wanted to recruit patients within 3 hours of symptom onset, but then halfway through the trial, they expanded that to 4.5 hours, citing some pilot study that suggested that the difference in hematoma expansion between 3 and 4.5 hours wasn't significant. But changing enrollment criteria is the academic equivalent of egg on your face. It's not really a methodologically sly maneuver. And of course, all hemorrhages are not created equal. I think it was really smart that they tried to limit the enrollment to patients that had at least a chance of reasonable recovery by limiting the size of the hemorrhages. But this paper kind of lumped all the different intracerebral hemorrhages together. I can't say that I buy that a hemorrhage with a 15 millimeter volume is going to have the same effect in a compact 35-year-old brain as it would in an atrophied 85-year-old brain, or that a patient that presents with a GCS of 14 is the same as a patient that presents with a GCS of 5 or 6. I think maybe their inclusion of such a wide GCS range and such a wide age range may have bit them in the statistical buttocks, and maybe a little bit of pre-planning for appropriate subgroup analysis or maybe just narrower inclusion criteria might have been helpful. But my biggest gripe? We don't honestly know that lowering the blood pressure at all does anything good. It could be that this whole argument is just much ado about nothing. The reason we lower the blood pressure is because a bunch of experts sat around a table and agreed that it was a good idea to do so. The current guidelines give lowering the blood pressure a level 2B recommendation for improving functional outcomes, which means they think it's reasonable to lower the blood pressure based on a level of evidence that consists of a single RCT or an observational study, i.e. crappy data. In fact, they specifically cite Interact-2 as the one RCT, which, despite some statistical jujitsu, failed to show any benefit overall. And they have ZIP for patients with a blood pressure of greater than 220, citing a level of evidence C, which basically means expert consensus. Call me crazy, but one of these days we really should consider a control group where we leave the blood pressure alone and find out if we're doing something good or causing harm, because this would not be the first time where a physiologic argument that sounded really good turned out to be completely wrong. So the bottom line here is that early aggressive lowering of the systolic blood pressure to less than 140 does not improve outcomes, and the best data we have to date suggests that it may be harmful. The caveat here is that as of this recording, this trial is new enough that both the European and US guidelines still recommend lowering the blood pressure to less than 140 within 6 hours of presentation. So it's probably a good idea to talk to your consultants for consensus in light of this newly published trial. At this point, lowering the blood pressure is still the standard of care, and we just need to come to some agreement of what that goal should be until we have better data to guide us. And of course, don't get so focused on the medical management that you forget that a nicardipine infusion isn't the only thing we can do to help control blood pressure in these patients. If we take the time to control pain, manage anxiety and agitation, empty full bladders, and look after the comfort and other needs of these patients, sometimes that alone will solve the blood pressure problem for you and obviate the need for aggressive management. All right, it is time for the big finish. Let's review what we learned from our 5 papers. Lidocaine or amiodarone did not improve survival or functional outcomes for patients with out-of-hospital VFib or VTAC cardiac arrest. For patients with a VFib or VTAC cardiac arrest, wait until after the second shock to give epinephrine, as early administration of epi was associated with worse patient outcomes. Early intubation does not improve survival from in-hospital cardiac arrest. Focus on the more important interventions first, like good compressions and defibrillation. Peripheral vasopressors can be used safely for short-term use. And lastly, lowering the systolic blood pressure to less than 140 did not improve survival or functional outcomes in patients with spontaneous intracerebral hemorrhage. Well, that wraps it up for this one. Have a great summer, And until next time, please enjoy this shout out to Simon's cat, a fantastic episode that perfectly sums up the phenomenon that is cats in boxes. Take care.
Mm-hmm.